Hello, everyone, and thank you for joining today's CMS Web Interface support call. During this webinar, CMS will provide an overview of the 2020 CMS Web Interface quality reporting for MIPS ACOs, groups, and virtual groups. After the webinar, CMS will take as many questions as time allows. Now I will turn it over to Carla to begin.
Thank you. Welcome, everyone, and thank you for joining us today as groups, virtual groups, and ACOs prepare for CMS Web Interface quality reporting. I'm Carla Sturl from CMS, an expert on the CMS Web Interface. Joining me on the call today are other experts who will share helpful information on CMS Web Interface quality reporting and answer your questions during the question and answer session after today's presentation. Today's call will only focus on 2020 quality reporting. Please note that any measure guidance provided during this presentation is specific to the CMS Web Interface. When using other collection types to submit data, you should refer to the measure specifications applicable to the collection type used. You can contact the Quality Payment Program Service Center with any of your questions regarding cost, promoting interoperability, improvement activities, MIPS, or quality reporting in general. Next slide, please. This is a disclaimer slide about this presentation. Information in this presentation is current at the time it is published, but I urge you to please be sure that you're using the source documents and links that are provided throughout the presentation. And please stay tuned to any communication from the Quality Payment Program, Shared Savings Program, or Next Generation ACO model regarding any updated information. Next slide, please. Announcements and reminders. Next slide, please. The CMS Web Interface will close promptly at 8 p.m. Eastern Daylight Time on March 31st, 2021. Your submission will be automatically accepted once submission closes. As a reminder, the CMS Web Interface is accessible using the sign-in link on the Quality Payment Program website circled here. Next slide, please. The materials from the January 27th, February 10th, and February 24th support calls are posted on the QPP webinar library. Next slide, please. The last support call will be held Wednesday, March 24th, 2021 from 1 to 2:30 p.m. Eastern Time. Topics will include frequently asked measure questions regarding the following measure, CARE 2, falls, screening for future fall risk. Additional topics may be added prior to the support call. Next slide, please. The 2020 CMS Web Interface API is available all year for testing in the developer preview environment. Please review the links listed here for more information. Next slide, please. Other CMS approved reason requests must be submitted through the CMS Web Interface. Requests should be reserved for circumstances that are unique, unusual, and not covered by any of the denominator exclusions or denominator exceptions identified in the measure specifications. Please review the 2020 measure specifications thoroughly before submitting a request to skip a patient. Next slide, please. Once you have submitted an other CMS approved reason request, additional information may be requested from you. If further information is requested, you will receive an email from PIMS Quality Measures Support at gdit.com. If the requests for additional detail are unanswered, the request will move forward in the review process using the information available. Once a decision has been issued, the request can't be reopened. Submitting any request for an other CMS approved reason during the last days of submission could cause your request not to be processed. 2020 other CMS approved reason requests submitted after Friday, March 19th, 2021 may cause your request not to be processed prior to the close of submission. Submit such requests as soon as possible. Now, I will hand things over to Katie Moore to go over frequently asked measure questions.
Thank you. Next slide, please. Okay, we are going to discuss frequently asked measure questions in this next segment. Next slide, please. The first measure we're going to go over today is the DM2 measure, diabetes hemoglobin A1C for control. The intent of this measure is for patients 18 to 75 years of age with diabetes who had a hemoglobin A1C of 9% during the measurement period. For this measure, a lower performance rate indicates better performance or control. For the use of telehealth within DM2, the documentation of the most recent HbA1c results may be completed during a telehealth encounter. Next slide, please. Now we'll go over some Q&A. Question 1 is, will patients only be included in the measure if they have a diagnosis of diabetes during the measurement year, or will they be included if they have a prior diagnosis, but not necessarily one during the measurement year? So the answer to this is history within the measure specification refers to the year before the measurement period. An active diagnosis refers to the measurement period. So for the 2020 performance period within the measure, you would need to confirm a diagnosis of diabetes is documented in the medical record in 2019 or in 2020. Question 2, do I use the date the blood was drawn or date of the lab results? The answer is it's appropriate to use the following ranking when considering performance of the numerator for the DM2 measure: lab report draw date, lab report date, flow sheet documentation, practitioner notes, or other documentation. Question 3, will HbA1c values from any setting be acceptable for the 2020 reporting period? The answer is yes. The measure specification doesn't limit the HbA1c to a specific setting. Next slide, please. Question 4, are continuous glucose monitoring system results acceptable for the numerator? The answer is no. The 2020 measure specification for DM2 does not include CGM results, whether patient reported or from the clinician. There must be medical record documentation of a distinct HbA1c value and the date the blood was drawn. Question 5, are patient-reported values accepted? The answer is yes. Patient-reported HbA1c values are allowed as long as the date and most recent value are documented in the medical record. Next slide, please. Now we're going to discuss MH1, depression remission at 12 months. The intent of this measure is for adolescent patients aged 12 to 17 years and adult patients of 18 years or older with major depression or dysthymia to reach remission 12 months after the index event. Regarding the use of telehealth for MH1, PHQ-9 or PHQ-9M administration doesn't require a face-to-face visit. Per the measure specification, multiple modes of administration are acceptable. This includes telehealth, e-visit, email, patient portal, iPad or tablet, or patient kiosk. Patient remission, which is a follow-up PHQ-9 or PHQ-9M result less than 5, may be determined during a telehealth encounter. Next slide, please. Okay, now we'll go over some frequently asked questions regarding MH1. The first is, a PHQ-9 has been completed on the patient paper form and scanned into the medical record, but the score wasn't totaled. Is it acceptable to calculate the score during abstraction? The answer is no. If the score isn't totaled in the medical record documentation, it shouldn't be used for purposes of reporting for MH1. Question 2, if a patient answers the first 2 questions of the PHQ-9 or PHQ-9M as not at all, and the rest of the questions are blank, is the depression screening considered numerator compliant? No. All 9 questions must be answered to have a valid summary score. There must be medical record documentation of the score and date completed. Question 3, the measure specification states this 14-month measure assessment period allows for the measurement of the patient's remission status at both 6 and 12 months. Does this mean the patient must have a PHQ-9 or PHQ-9M score of less than 5 at both 6 and 12 months? No. The intent of the measure is to evaluate how many patients reached remission at 12 months, which is plus or minus 60 days after the index event. Next slide, please. Okay, question 4. If a patient has multiple PHQ-9s during the denominator identification period, which PHQ-9 should we choose to determine if they meet the inclusion criteria? So in order to be considered eligible for the denominator, you would need to enter the first instance where the PHQ-9 or PHQ-9 assessment was determined to be greater than 9 and was associated with a diagnosis of major depression or dysthymia during the denominator identification period. This is the index event for this patient and marks the start of the 14-month measure assessment period. And finally, if the patient had more than one PHQ-9 administered during the measure assessment period, which should we use? So this measure assessment period is to determine remission for the patient. So if more than one PHQ-9 or PHQ-9M score was obtained during the measure assessment period, you would use the most recent assessment to determine if the patient achieved remission. Next slide, please. Does the 12-month time frame need to be calculated at exactly 12 months from the index date? No, the date doesn't need to be exactly 12 months. The measure assessment period for each patient is 14 months, which is 12 months plus or minus 60 days following the index date. This assessment period is fixed and doesn't start over with a higher PHQ-9 or PHQ-9M that may occur after the index event date. Next slide, please. Okay, that brings us to the end of our frequently asked measure questions. For today, I will hand things back over to Carla. Thank you.
Thank you. These next few slides will outline the available CMS Web Interface resources. Next slide, please. Please note that 2020 materials providing information on the MIPS Quality Performance category are available on the Quality Payment Program Resource Library. We encourage reviewing these resources if you have questions on quality requirements and measures. We'll continue to communicate any future postings in upcoming support calls. Additionally, the Help and Support page on the QPP website contains links to materials such as videos, webinars, and online courses, as well as other items to help with reporting and development. Next slide, please. Finally, this slide contains links to resources available for Shared Savings Program and Next Generation ACO model. We encourage you to review the materials available here for more information. Next slide, please. If you need additional assistance, please refer to the contact information listed on this slide. Next slide, please. CMS has no-cost resources and organizations to provide help to clinicians who are participating in the Quality Payment Program. Learn more about technical assistance by following the link on the slide. Next slide, please. Now, just before we head into the Q&A portion of this call, if you're interested in providing feedback and collaborating with CMS on the Quality Payment Program, we encourage you to participate in our human-centered design efforts. To get involved, please email your name, title, topic of interest, and organization to qpp.userresearch@cms.hhs.gov. Now, I will hand things over to Haley Burnside to begin the Q&A. Thank you.
Great. Thank you, Carla. So now we will begin the question and answer portion of this webinar. Please submit your questions via the Questions tab on your screen or raise your hand and we will unmute your line. All right, so we have our first question, and this is for Prev 13. Will hypercholesterolemia and E78 meet intent?
Hi, this is Katie from the PIMS team. So just to elaborate on the question a little bit more, I think it's asking whether there's documentation of hypercholesterolemia alone associated with that particular code. So just to reiterate, the measure specification does require confirmation of a diagnosis of pure or familial hypercholesterolemia that can be demonstrated with a combination of written documentation and coding. So if both are present and you can confirm pure or familial hypercholesterolemia, that can be used. Thank you.
Okay, and our next question for Prev 12, does the name of the tool need to be present or can the question specific to PHQ-2 meet intent?
Hi, this is Katie from the PIMS team again. So as mentioned in past calls, CMS has decided to allow the same types of documentation that were submitted during the 2018 performance period for 2020. If you've updated your system and your system currently reflects 2019 or 2020, CMS will accept documentation that aligns there. So in this instance, if the questions are present in the EHR, but there's no specific title for the depression screening, that would be considered accepted as long as, again, those questions are documented within the EHR. Thank you.
Okay, great. And our next question is on MH1, and this states that our EMR form is labeled a PHQ-9, but if the first two questions are negative, the rest of the questions are not answered. Do you know if the first two questions are negative, can that be counted as a negative PHQ-9?
Hi, this is Angie from PIMS. I'm sorry. The measure specifications state on page 13 that all 9 questions must be answered to have a valid summary score for your PHQ-9 or PHQ-9M for the MH1 measure. Thank you.
Great. And our next question is on Prev 13. What should you put on the LDL questions in the statin measure if no LDL-C was done in the measurement period? Select no diagnosis.
Hi, this is Katie from the PIMS team again. So just to make sure that we're covering all our bases, there's population 2 and population 3 both include the LDL-C, and they both have different time parameters around when those would be applicable. So for population 2, it's patients who have ever had a fasting or direct laboratory test result of LDL-C greater than or equal to 190. For population 3, it would be LDL-C result of 70 to 189 recorded as the highest fasting or direct laboratory test result in the measurement year or during the 2 years prior to the beginning of the measurement period. So I guess we would just encourage you to take another look at which population you're referring to see if there's an applicable result during those time frames. And page 8 of the measure specification also provides additional guidance on the laboratory test results. And I believe in the denominator confirmation portion of the measure specification for each population, there are options to report out that patient if it doesn't apply. So in regard to population 2, if it doesn't apply, you would report no diagnosis. For population 3, if a patient doesn't have an LDL-C of 70 to 189 documented, you would select no during that portion. Thank you.
Great. And our next question is for DM2. Per the CMS documents, a glycohemoglobin A1C meets the screening requirement. Does the lab have to indicate A1C, or is the name glycohemoglobin suffice?
And this is Deb from the PIMS team. As long as that clinician is using documentation of glycohemoglobin as the A1C distinct result, it would be appropriate. Based on the definition of a glycohemoglobin, it is likely it would meet the measure requirement. However, if you have concerns, it may be best to follow up with the clinician. CMS is unable to provide specific feedback regarding whether or not documentation in the patient's medical record, including screenshots, would meet the intent of the measure or suffice for a given measure in the event of an audit. And in this case, the verbiage that you're asking about is not identified in the synonyms provided in the specification by the measure developer. Therefore, it would be best for you to ensure that there is a distinct value within the medical record. And again, if you have concerns, it would be the clinician that could give you that feedback. Thank you.
Okay, thank you. And our next question is on HTN. They're asking, if during a telemedicine visit, if a provider notes that home BP readings are above ideal and the last recorded reading was 140/80, for example, it does not specify if it was recorded by a home monitoring device or if it was recorded by the patient. It does not specify or how or whom it was taken by. Would it be correct not to use this reading as it appears to be lacking details?
No, for this measure, you are looking for the most recent blood pressure for documentation. So you would use that blood pressure.
Thank you. And our next question, can we get confirmation that PREV-10, PREV-12, and MH are the only pay-for-reporting measures for ACOs in performance year 3?
Hi, this is Kristen from RTI. For ACOs in performance year 3, it's actually PREV-12, PREV-13, and MH that are the only web interface pay-for-reporting measures, so not PREV-10. Thank you.
And our next question is, will the web interface be available for use for quality reporting next year for the PY 2021 data?
Hi, this is Lisa Marie. Thank you for that question. And I just want to note that for performance period 2021, that will be the last performance period in which the web interface will be available as a collection type, as a submission type also. So next year, and actually this year, we are encouraging all web interface users to prepare to transition to utilize another collection type after the 2021 performance period. Thanks.
And our next question is on HTN2. If a patient has a BP taken in an office or urgent care setting, and the patient presents to the emergency department later on the same day, is the BP taken in the outpatient setting subject to exclusion?
Hi, I'm sorry. So this is Carol, and in this case, you can use the next most recent visit, which would be the urgent care and/or office visit, since the ER visit is excluded from the numerator. I should clarify that and say the ER blood pressure would be. Thank you.
Okay, thank you. And our next question is on PREV-10. Documentation on several visit progress notes in 2020 patient states she is not interested in counseling or medication. Does this count as cessation counseling since it was addressed?
Yeah, this would count as cessation counseling, even though the patient was not compliant. The intent of the measure is just to provide cessation counseling to those patients that are identified as tobacco users. So this is appropriate.
All right, great, thank you. And our next question on Care 2, progress note states gait is normal. Does that meet the?
Hi, this is Carol. Yes, as long as you have medical record documentation of gait normal, it would meet the intent of the measure, and it addresses that the patient has been screened. That's it, thank you.
Thank you. And our next question is on PREV 6. If a colonoscopy was performed on a patient, however, due to reasons beyond the provider's control, the result was not fully conclusive or procedure was not fully completed, would the screening still meet the intent of the measure?
Hi, this is Angie. The measure specifications do say that the test, the screening has to be completed to meet the intent. So you may want to possibly submit another CMS approved reason for this patient if you feel that the circumstances are unique, unusual, and not covered by any of the denominator exclusions or exceptions. When you do, please provide as much information as possible, whether another screening was scheduled or another type of screening was offered, and any medical record documentation you have regarding the colorectal cancer screening. Thank you.
Great, thank you. And our next questioner asks, with the increase of telehealth during the pandemic, did I interpret correctly that if the patient took his or her BP while the provider was on the phone or video visit, and if that patient reported value was documented in the EMR, is that acceptable for the numerator during the pandemic?
That is correct. Let me read you what has actually been reposted in the FAQ for your, I guess, reference if you need to look back. So a blood pressure taken by either a clinician or a remote monitoring device, home device, or a device brought by a visiting nurse or caregiver and conveyed by the nurse or caregiver or by the patient to their clinician is acceptable for the numerator as long as it's the most recent blood pressure reading documented in the medical record for the patient during the measurement period. In addition, related to remote monitoring, since the measure guidance and specifications do not define what constitutes a remote monitoring device or methods of conveying the blood pressure from a remote monitoring device to the clinician, we are unable to provide guidance on a specific device or a specific workflow on how the clinician interacts with patients using remote monitoring devices during a telehealth encounter. So it is up to the clinician's discretion as to whether or not the remote monitoring device used to obtain the blood pressure is considered acceptable and reliable. So this information can also be found in the FAQ on the CMS resource page for your reference as well. Thank you.
Thank you. And we do have a follow-up question to one of the questions we previously went over. So this is asking, would the provider statement of patient declines all vaccinations at this time be sufficient for a denominator exception, patient reasons?
This is Deb, and I am assuming that we're talking about the PREV 7 question. And I will say that the medical record documentation should support that the refusal, exception, or the receipt of the vaccine occurred during the appropriate time frame. And for 2020 reporting, that would be from August of 2019 to March of 2020. Denominator exceptions must be specific to the flu season being reported, and the documentation should occur during the measurement period and be specific to the flu season as well. And this is confirmation and feedback we have received from PCPI. It includes the egg allergy. Everything about the flu vaccine should be relevant to the flu season being measured. And again, the dates for that for the 2020 reporting period are August of 2019 through March of 2020. Thank you.
Great, thank you. Then our next questioner asks, did you say on the last call if you would accept the provider having talked with the patient about getting a colon cancer screening or mammogram, and that if tests were ordered, Is that sufficient documentation that the provider did all they could to meet the QM? And would that make the QM with the patient compliant?
Hi, this is Katie from the PIMS team. So no, that's not considered compliant for PREV 5 and PREV 6. The screenings must be completed and the results documented in the medical record in order to meet numerator compliance for PREV 5 and PREV 6. Thank you.
Right, and our next question seems to be in relation to that. So they're asking, if we have patients who refuse a mammogram or colorectal cancer screening, can we exclude them from the PREV 5 or PREV 6 denominator?
Sure, and this is Katie again. So no, neither of these measures have denominator exclusions for patient refusal. So that would not be applicable in the instance of PREV 5 and PREV 6.
All right, thank you, Katie. Our next question is on the PREV 12 depression screening. Does the medical record have to explicitly state patient scored positive for a PHQ-2 if PHQ-2 score is documented in the chart?
Hi, this is Katie again. So the measure specifications outline that a specific score isn't required, just whether the results of the tool are considered negative or positive. And if positive, obviously a documented follow-up plan would be necessary. The only instance where a score can be assumed to be any result is in the instance of a score of 0, and that can be assumed negative. Otherwise, an interpretation is necessary. The way in which that is worded, or if it needs to explicitly state anything within your medical record, isn't outlined. So it would really be up to your internal workflow as to how that's implemented and how that's worded within your medical record documentation. Thank you.
All right, and our next question. If we have a patient who does not receive a mammogram because they have breast implants and get an MRI instead, can we use an MRI breast cancer screening during the time period as a compliant service for PREV 5?
Hi, this is Angie. It is not acceptable for the numerator for the measure, no. You can submit, again, a CMS request for proof reason, and be sure to include all of that documentation, the date of the MRI, the age of the patient, and their applicable diagnoses, and send that in for a reason to skip. Thank you.
Great, and our next question is in regards to a colonoscopy screening measure, FOBT. The specimen was taken in the office setting and performed by the office lab. Is it okay to use the result of the FOBT test?
Hi, this is Angie again. No, it is not. FOBTs performed in an office setting are not acceptable for the numerator, and you can find that in the numerator section of the measure specification. Thank you.
Thank you. And our next question is on HTN1. Can you clarify the definition of remote monitoring device for patient-reported BP values? If a patient is using an automated or manual blood pressure cuff that was purchased by the patient on the recommendation of a clinician, considered a remote monitoring device?
Okay, hi, this is Carol. Let me review the definition that we have here, which is really not a definition because it is not within the measure specification. So the measure specifications do not define what constitutes a remote monitoring device or method of conveying the blood pressure for a remote monitoring device to the clinician. So we are unable to really provide guidance on a type specifically of the device or the workflow in which you would receive the information related to the telehealth encounter. So it is up to the clinician's discretion as to whether the remote monitoring device used to obtain the blood pressure is considered acceptable and reliable. I hope that helps. Thanks.
Thank you. And our next question, what is the expectation of smoking cessation for patients who are identified as non-compliant but have only ever had passive smoke exposure documented?
Hi, this is Jamie. Thanks for this question. In the instance you have a patient that is identified as a passive smoker, the measure really is just looking for those folks that are really using tobacco, so passive use is not considered as a positive screen. Again, the measure's intent is for those that are actively using tobacco and not passively taking it in. Thanks.
Okay, and our next question. For fall risk, would an intake form that has an item of at risk for fall, yes, no, where either answer is checked off, is that acceptable documentation?
Hi, this is Carol. Really can't speak specifically to that, your documentation per se, other than that, for this measure, so any history of falls or documentation of falls or fall screening is acceptable for this measure. So a gait or balance assessment meets the intent of the measure. I think that's it. Thank you.
Thank you. And our next questioner asks, can you repeat the comments about gait normal and which measure that relates to?
Oh, hi, this is Carol. Yes, so for the gait normal medical record documentation, gait normal would meet the intent of the measure and addresses that the patient has been screened. So the use of assessment is not specific to the use of screening tool, but may also include an assessment performed with or without a screening tool by the clinician. Thank you.
Great. And our next question is for Care 2. Can I use if the doctor stated in an office note that referrals, physical therapy offered for gait and balance and mobility evaluation, fall prevention?
Hi, this is Carol. As long as there's medical record documentation that there was a screening for future fall risk, which this sounds like it was, completed during the measurement period, this could include an assessment of whether an individual had experienced a fall or problems with gait or balance. A specific screening tool is not required for this measure. However, potential screening tools can include the Morse falls scale and the time to get up and go, and any history of fall screening during the measurement period is acceptable as meeting the intent of the measure. Thank you.
All right, thank you. Let's see. And just a quick reminder to ask a question, please submit it into the questions box or raise your hand and we will unmute your line. And we will stand by for our next question. Okay. And our next question is on MH1. When does an exclusionary diagnosis need to occur, such as bipolar? Should this diagnosis appear during the identification period of, say, November 1st, 2018 through October 31st, 2019, or can it appear any time between November 1st, 2018 and December 31st, 2020?
Hi, this is Angie. You can find that information on page 11. It states that the denominator exclusions must, the active diagnosis of bipolar, for example, would have to be any time prior to the end of the measurement assessment period. Thank you.
All right, thank you. And we will.
I'm sorry.
Oh,
Could
sure,
I add
go ahead.
something to that? So not to be confused with the denominator identification period. So the measure assessment period is going to be for that individual patient based on the start of it would be his index event date. And I'm sorry, I wanted to define that for him, for her. Let's see. Well, I apologize. The measure assessment period is going to be your index event date, and that starts that period, and that's going to be 14 months, be 12 months plus or minus 60 days from the index event date. Thank you.
All right, great, thank you. And our next question is for Prev 5 and Prev 6. Is the complete date required, or will month and year suffice?
This is Deb from the PIMS team. For Prev 5 and Prev 6, basically your documentation needs to support that those screenings occurred in the appropriate time frame. So if your documentation without the specific date supports that, then that is sufficient. However, if the date is needed to show that that measure has been met, you would need the specific date. I think in both of those cases, in Prev 6 for the colorectal cancer screen, you're looking at years and not specific months or dates being required. So if you have, the year and the month, you're going to be able to show that the measure has been met. With the Prev 5 breast cancer screening, there is a grace period, and so months definitely at times are required. The thing to remember, and where CMS doesn't want to get into specifics that are outside of what is documented in the measure specifications, is that whatever it is you're seeing in the medical record basically needs to be supportive of what you are reporting. And because those medical records can include so much more information than what we can see, we cannot speak specifically to a documentation that you're seeing. So it's more a matter of you being able to take that measure specification, review it, and then make sure that your medical record documentation is supportive of what you are reporting. Thank you.
All right, thank you. And our next question is on Prev 5 again. If the results of the mammogram are acknowledged in the medical record and the PCP, but the study results themselves are not found, does this qualify for the numerator?
Yes, and again, if you look at the measure specification, you are looking for, documentation of results. As long as you have medical record documentation of a result of some sort, that is sufficient. You don't need to have the specific mammogram to say that you've got the results and that the mammogram was done. Thank you.
Okay. And then we have another question for Prev 5 and Prev 6. Is it okay for a physician to document that screenings were negative or positive as opposed to normal or abnormal?
And this is Deb again. Yes, as long as you have documentation of the results in some shape or form, that is sufficient. We do say within the medical or within the specification for Prev 5 that normal or abnormal is acceptable. But basically, again, if you review that measure specification, you are looking for results of the mammogram to have been reviewed by the eligible clinician. And then that's just to ensure that everyone is aware of the results of that mammogram. Thank you.
Okay, and our next question is for Prev 12. If a provider does not total 0 plus 0 on the PHQ-2, is this enough, or do we need to see a total to be acceptable?
Hi, this is Katie from the PIMS team. So again, this is an instance where CMS can't comment on your internal workflow or provide specific feedback whether particular documentation would meet the intent of the measure. So we would just emphasize again that your medical record documentation should support the information provided, and however that is implemented within your workflow and your organization is really up to you to determine. Thank you.
Okay, great. And our next questioner is asking if you can please repeat the answer in regards to ACOs in year 3 and reporting information for PREV 10, 12, and 13.
Yeah, this is Kristen. So for ACOs in performance year 13, the only paper reporting measures are PREV 12, PREV 13, and MH1. So PREV 10 is not a paper reporting measure for ACOs in performance year 3.
Okay. And for MH1, is the measure assessed period 12 months out plus or minus 60 days from greater than 9 and then PHQ 9, or is it a total of 14 months to look for remission?
Hi, so this is Katie from the PIMS team. So the 12-month window, it's 12 months plus or minus 60 days from the index event. So that is the first instance of the PHQ 9 greater than 9 associated with the diagnosis of major depression or dysthymia. After that, you have 12 months plus or minus 60 days, which is also referred to as the 14-month sort of window to determine if the patient reached remission. So your index event marks the start, and then you have 14 months following that date to evaluate for remission. Thank you.
And our next question is for PREV 10. We screen patients for tobacco use. If a patient is positive for tobacco use, education and resources for cessation are discussed with the patient and also included in DEPART education to the patient. When the staff completes the DEPART discussion, they chart patient verbalizes understanding of DEPART information. Does this meet the intervention for the PREV 10 measure?
Hi, this is Jamie Welch. We actually received this question yesterday via the help desk, ServiceNow help desk. So I'm going to go ahead and just provide that response that we included within that inquiry. We just indicated that due to the comprehensive and individual nature of patient medical records only available to CMS Web Interface reporters, CMS cannot provide specific feedback regarding whether or not documentation in the medical record, including screenshots, would meet the intent of the measure or would suffice for a given measure in the event of an audit. In the event of an audit, auditors will review measure specifications in comparison to the patient medical record documentation provided by an ACO MIPS group, a virtual group for each patient sampled for the audit. And for purposes of 2020 CMS Web Interface Measure PREV 10, there should be medical record documentation of tobacco cessation intervention if the patient is identified as a tobacco user. Tobacco cessation intervention includes brief counseling, 3 minutes or less, and or pharmacotherapy. So please let us know if that response, if you need more clarity with that, feel free to reopen that incident and we can take a further look at it or perhaps get on the phone with you. Thank you so much.
And then we do have a similar question for PREV 10. Does the cessation intervention have to occur after the most recent tobacco use screening where a patient is identified as a tobacco user, or can it occur anytime within the 24-month look-back period where a patient was identified as a tobacco user?
Hi, this is Jamie again. Thanks again for this question as well. Cessation can occur anytime within the 24 months. Thank you.
Okay, and our next question is on PREV 13. If the patient is prescribed statin therapy at any time during the measurement period, whether they are compliant with the medication or not, can you answer yes to the statin therapy here?
Hi, this is Katie from the PIMS team. So the answer here is yes. The measure isn't calculating patient adherence to the statin, but rather that the patient was prescribed a statin. So as long as there's documentation of the prescription for the patient that will meet the intent of the measure. Thank you.
Thank you. And our next question is for MH1, and they're asking to clarify if a patient scores 10 or higher and then is screened a month later with and scores a 3, this would be compliant. Why does it give a plus or minus 60-day window rather than just a 14-month window?
Hi, so this is Katie again. So just to clarify, I believe this question is related to screening for remission, and the window is really to give the clinician time to reach that 12 months without having to stick to a specific date. So if there's multiple screenings within that measure assessment period, which is the 12 months plus or 9 to 60 days, in that case, the measure specification does state to use the most recent screening when determining patient remission. Thank you.
All right, thank you. And moving on to our next question. In order to apply the denominator exclusion for patients age 66 and older with at least one claim or encounter for frailty during the measurement period and a dispensed medication for dementia during the measurement period or the year prior to the measurement period, is it necessary to have both a frailty diagnosis and a frailty encounter code to meet this exclusion?
Hi, this is Angie. You do need one claim or encounter for frailty, so that could be just the diagnosis of frailty. The easiest way is to go to the Appendix 2, which is included in any of the measure specifications, but that have this exclusion, and look at the downloadable resource mapping table. So it's going to, so those are all or statements. It's a little bit better illustrated there, and it will show you which codes to look at for each of the exclusions, but it is an or statement, so no, you do not need both. Thank you.
Our next question is for Prep 13. Does the question, did the patient ever have LDL-C higher than or equal to 190, apply to only during the measure period January 2020 through December 31st, 2020, or at any time?
Hi, this is Katie from the PIMS team. So the measure is looking for any history, not limited to the performance period. And if you go to page 13 within the measure specification, there's a little bit more guidance offered there. So for purposes of the measure, a previous or current diagnosis of familial or pure hypercholesterolemia would be acceptable to satisfy the criteria in denominator 2 population. However, in the absence of an official diagnosis, if the patient has an elevated cholesterol, which is that LDL-C value greater than or equal to 190, either historical or current, this would satisfy the intent of the denominator eligibility for population 2. Thank you.
Great, thanks, Katie. And moving on to our next question that is on CARE 2, would documentation of a limp count since it is an assessment?
So this is Deb. As long as your documentation supports a falls risk assessment, it would be sufficient. Again, we can't specifically speak to your medical record documentation. I would recommend that you review the measure specification for what constitutes a falls risk assessment and use that in combination with what you are finding in the medical record documentation.
Great, thank you. And moving on to our next question for the flu shot, if the clinician notes, it killed my uncle and I am afraid, but there is no wording or of refusal, will this qualify? The notation does fall within the appropriate time frame for the flu vaccine.
And this is Deb from the PIMS team again. Unfortunately, we can't assume anything, and in this case, I would recommend looking more through the medical record documentation. The requirement is that a patient refuses the vaccine, and that is documented. As you can see based on your question, this is why CMS does not want to specifically address medical record documentation, as there could be more that is documented. And again, we can't assume that by being afraid of the vaccine, the patient refused it. Thank you.
Okay, and our next question is for HbA1c. If you have medication noncompliance documented by multiple physicians for a patient with a hemoglobin greater than 9, can that patient, is there any way to exclude this patient?
This is Deb from the PIMS team again. Unfortunately, the measure developer did not include an exclusion for patient noncompliance and then the result of their hemoglobin A1C being out of control. For the purposes of the CMS Web Interface, there is the option of submitting a CMS approved reason request and having the medical officer review and determine whether or not that patient should be skipped. But if you're looking at this from the measure perspective, the measure developer did not include an exclusion for that reason. Thank you.
Okay, and our next question is on PrEP 7. If a patient had a flu vaccine at Walgreens in August of 2019, but did not have their annual wellness until May 2020, and the doctor documented flu vaccine August 2019, is that a pass or fail?
So again, for the flu vaccine, as long as your documentation is supportive of the patient refusal, receipt of the vaccine, system reason, medical reason for not receiving the vaccine, any of those, as long as your medical record documentation supports that the information you're providing is specific to the flu season being measured, it would be acceptable.
Thank you. And our next question is, PHQ-9 requires a physician interpretation as well as a score and date. Is that correct?
Hi, this is
And this
Katie
is in regard to PrEP 12. Yes.
Yeah, thank you. So the measure specifications for PrEP 12, if you go to page 11, there's some guidance within the numerator there. So it says the measure doesn't require a specific score, just whether the tool is considered negative or positive. And then if the result is positive, there'd be documentation of a recommended follow-up as required in that instance. So then going back to earlier questions, the way in which that's documented or worded within your medical record as to how the clinician, I guess the specific wording the clinician uses as to whether it's negative or positive is up to your internal workflow. We can't provide additional guidance there. Thank you.
Okay, thanks, Katie. And our next question is for the HTN2 measure. Will unspecified hypertension qualify for the measure, or does it have to state essential HTN?
Hi, this is Carol. No, you are looking for essential hypertension, and you can refer to the coding to find out what conditions the measures consider to be essential hypertension for this measure. Thank you.
Thank you. Our next question, if a patient was referred to physical therapy for assessment of gait, balance, or fall, will this be acceptable as a fall risk screening, even though PCP did not screen for fall risk, but yet referring to physical therapy?
So this is Carol. That's a tough one. However, can't really, I guess, assess that from that standpoint. However, I can tell you what screening is, so you can make that determination. So screening for future fall risk is an assessment of whether an individual has experienced a fall or problem with gait or balance. A specific screening tool isn't required for this measure. However, potential screening tools include the Morse-Falls scale and the timed get up and go test. So for the numerator guidance, documentation of no falls is sufficient. Medical record must include documentation of screening performed. Any history of falls screening during the measurement period is acceptable as meeting the intent of the measure. A gait or balance assessment meets the intent of the measure. So if after reviewing the medical records, you find supporting documentation that meets the numerator guidance criteria, then it would meet the intent of this measure. Thank you.
Great, thank you. And we will now move to our phone line question. So Catherine Fernandez, your line is now unmuted. And Catherine, you may be self-muted. Okay, we will try and come back to Catherine. We'll go back to our questions box. So can MH remission be clarified, please? Can the PHQ-9 reassessment be at any time in the 12-month time frame, even if it's 4 months post the initial assessment? Or does it have to be at 12 months plus or minus the 60 days?
Hi, this is Angie. It does have to be at 12 months plus or minus the 60 days. You can find more information on page 7 where it defines the 12 months. And it does say that values obtained prior to or after this period are not counted as numerator compliant for remission. Thank you.
Great, thank you. And at this time, just as a quick reminder, to ask a question, please submit it via the questions box or raise your hand and we will unmute your line. Right, then we will just stand by for our next question.
This is Deb. I'll go ahead. There's a question in the queue right now, and I think I can address it. The question is, can you clarify the CARE 2 question that was asked? If provider recommends education on fall risk, does that suffice? And again, as Carol kind of read earlier, and I won't read the whole thing from CARE 2 as far as what defines a falls risk, but just keep in mind that the numerator of this particular measure is patients who are screened for future fall risk at least once within the measurement period. And based on that and what the measure is looking for, recommending education on a fall risk doesn't meet compliance necessarily on this measure. You're really looking for a fall risk assessment. Thank you.
All right, thank you. And just one more reminder, if there are any other questions, please submit those via the questions box or raise your hand and we will unmute your line.
And this is Deb again. I just saw one come in for Prev 7. If a provider calls a CVS, Walgreens, et cetera, and documents the patient flu shot after the flu season, does that meet? Basically, what you're looking for, again, within the medical record documentation for Prev 7 is that there is medical record documentation that supports the flu vaccine was either received or the flu vaccine was refused, there was a medical reason for not receiving or a system reason for not receiving that vaccine during the appropriate flu season being measured. Thank you.
All right, thank you. And we will just continue to stand by to see if there are any other questions that come in.
Haley, there was a question relating to when a user is in the web interface and they get a message indicating that the measure does not have a benchmark. I don't know where that is within the many questions, but that's a question I want to address for folks. So within the web interface, there are certain measures that do not have a benchmark. And in the instance of a measure not having a benchmark, reporting, all users need to complete reporting for that measure, even though there's not a benchmark. And when there's not a benchmark, that measure is considered pay for reporting or not scored under MIPS. So even though there's no benchmark, you complete reporting. And again, if you don't complete reporting for that measure, then it will be scored, in which it will impact your overall score. So it's important. So even though there's a measure and it doesn't have a benchmark, you still need to complete reporting for that measure. So if there are any other further questions relating to measures and benchmarks, and even let's say measures that are not going to be scored or pay for reporting, all of those measures still have to be completed by all users.
Thank you, Lisa Marie. And we will just make one more announcement. If there are any other questions, please submit those via the questions box or raise your hand and we will unmute your line. Okay, looks like we just got some phone line questions. So Josephine Osifo, your line is now unmuted. Josephine, you may be self-muted.
Can you hear me now? Hello?
Yes, we can hear you.
Okay, thank you. I actually put a question in for the OMW measure, osteoporosis management in women. I wasn't sure if you got that message. So I wanted to just ask the question. I'm trying to clarify something. On that measure, go ahead.
Hi, Josephine. You were asking that question in regards to osteoporosis management. That is not a web, we're tracking that not being a web interface measure, but an individual measure that is a Medicare Part B claims and a clinical quality measure, or CQM. So we were just wondering, for the purposes of this call today, if you would be willing to submit this particular question into the service center so we can address that question there and provide the support that you need in getting the right response.
Okay, I really appreciate that. Thank you so much.
Yeah, no problem, Josephine. I did leave a message in there. If you need the link, just a quick, it's qpp@cms.hss, oh wait, HHS, I'm so sorry, .gov. So sorry.
Okay, I'll get it. Thank you.
Yeah, no problem. Thanks.
Hey, and Heather Anderson, your line is now unmuted. And Heather, you may be self-muted.
Can you hear me?
Yes.
Okay. What was mentioned just earlier made me think. On the all-cause hospital readmission measure, I know MIPS says that it is excluded from scoring, but it says it's MIPS specific. So is that still a regular pay for performance according to the benchmarks that was set previously for MSSP scoring?
Hi, this is Fiona from the Shared Savings Program. We are still evaluating that at the moment, and we'll provide further guidance soon.
Thank you.
And Julie Martinez, your line is now unmuted.
Hi, I just have a quick question related to a skip request that was submitted on Monday. It looks like some additional research is happening, but can you provide guidance about, on average, how long it usually takes to get that response?
Hey, Julie, this is Katie from the PIMS team. So this really truly depends on the complexity of the skip request, how much information was provided in the skip request, and then we do have a pretty substantial review process for those. In terms of your case, I know there's some additional complexities with the ones that were submitted that we're actively working through. So I don't know that we have a specific time frame that we can provide, but just want to assure you that it is actively being looked at, in particular with CMS and other contractors who were involved in processing some of the things related to your case. So
Thank you.
we're working on it. It just might take a little bit of time there. So thank you.
I appreciate it. Thank you.
And Michael Levant, your line is now unmuted.
Hi, can you hear me?
Yes, we can.
Oh, perfect. So I'm actually the one who asked the question about the measure rates report out of QPP, and so I was hoping to get further clarification because I apologize, I'm actually a little further confused because based on the so bottom line is, I'll read to you the note that we got for Prev 10. It says, this measure does not have a benchmark. However, you've met the criteria or met the data completeness criteria by reporting data for all patients that were assigned to this measure. This measure will not be calculated in the denominator of your overall quality performance category score. So I just want clarification. Is this note in reference to MIPS or is it in reference to MSSP? Because if it's in reference to MSSP, then this unfortunately contradicts what we've been told that in this case, Prev 10 is pay for performance.
This is Fiona from the Shared Savings Program. So Prev 10 has a benchmark for web interface under the Shared Savings Program.
Okay. I guess then I'm not sure, and maybe I submitted this question to QPP, then why would we receive this note in the actual report that we downloaded from QPP? So that's I guess my next follow-up question.
So this is Lisa Marie. Just give me one moment, because Fiona, there was an issue, and I believe it's this Prev 10 measure. And I know that originally maybe it did have a benchmark, but someone from PIMS, can you please help me? Is this the measure in which SNOMED codes are removed?
Lisa Marie, that would have been Prev 12, the screening for depression. Prev 10 is smoking cessation measure. Yeah.
Okay. So let me look through that. But you're saying this was the message you received when you're in the web interface, when you actually completed reporting for Prev 10?
Yeah, one of the report options was to download the measure rates report. And when I download that, which downloads as an Excel file, and I go to the Prev 10 tab, there's a note that was pre-populated and that just stated what I read to you earlier. And so that's what my original question was. I was confused because I remember hearing that this was a pay for performance measure, yet this very clearly seems to indicate that it's not, and it's not even included in the scoring of our final quality score.
No, thank you for flagging that. And you mentioned that you submitted a help desk ticket?
I did, and then they responded back this morning asking for like a screenshot of this, in which case I responded with a screenshot of this report and this specific note in question. And I've not heard back yet. That was earlier this morning.
Okay, in the chat, can you include your case number so I can look to see who's so we can analyze and assess what's happening? Because I want to make sure that whatever communication or information that's being provided to you all, whether you're looking up a report or when you're actually doing your reporting in the actual web interface, that all the messaging is correct. So yes, please, if you can in the chat, so I can investigate the case number and we can assess and make sure that any information is provided correctly. And if needed, during next support call, we will clarify this. But yeah, I definitely think I need to investigate this issue further to make sure that there should be no confusion in terms of what a measure is in terms of if it is being scored, and then if communication from the system is saying something else. So thank you for flagging that, and we will investigate. And again, please include that in the questions or in the chat. Provide your case number so we can investigate.
Sure, happy to do that. I'll do that right now. And then if someone could just call us back, because I feel like something like this would be best discussed over the phone versus back and forth emails.
And that makes sense. So yeah, thank you. And I will be looking out for your case number. Thank you.
And Amanda Dunn, your line is now unmuted. And Amanda, you may be self-muted.
Can you hear me okay?
Yes, we can.
Okay. For PREV 6, we have a patient who has documentation that they had a colonoscopy with a polypectomy done in December of 2018 with no result documented. However, separately and on the same date, there's a pathology referral result that references that a tissue biopsy of a colon polyp was done. And we're just wondering if a surgical pathology report noting the specimen results of that colon polyp satisfies the measure for PREV 6.
Hi, this is Angie. Did you say that it was a colonoscopy with polypectomy that you had documentation of?
Yes, yes.
So I think documentation that that colonoscopy occurred and the date that it occurred would then support that the test was performed. If the results of the polypectomy are tied to that, and I think you said the same date.
Yes, the same date.
I cannot speak to specific medical record documentation, but you might want to just look at that, and if it is the result of something done during the colonoscopy, I would, it seems that that those could count as results. But again, we have to leave that up to the organization to determine.
Okay, thank you.
Thank you.
Okay. And Mary Hickey, your line is now unmuted.
Hi. If the patient scores positive on the PHQ-9 for PREV 12, but the doctor indicates in the record that they don't feel that there is any needed follow-up, is that met, not met, or is it an exclusion?
Hi, this is Katie from the PIMS team. So for PREV 12, if there's documentation that the patient was positive for depression, the measure would be looking for that documented follow-up plan for the patient.
So even though the doctor doesn't feel there's any necessary follow-up?
Yeah, I mean, the measure would be looking for treatment to that depression. And we might want to, I might refer you to submit a ticket just so we can look at this a little bit closer, because it could potentially be one thing if the doctor interpreted their depression screen was negative or something along those lines, but I'll have you submit this question to qpp@cms.hhs.gov, and just note that it's for 2020 CMS Web Interface Measure PREV 12. That way it can get routed as appropriate as quickly as possible.
Okay.
We just want to make sure that we are giving you the best answer here. So I think that's probably the best route to go.
Okay, thank you.
And Renee McCord, your line is now unmuted. Renee, your line is unmuted if you'd like to ask your question. Okay, we will try to come back to Renee, but I think we have time for a couple more questions. So going back to our questions box, for Care 2, if a provider states patient has a history of fall and does not say when the fall was, Would this qualify, or do we need more specifics to when the fall was?
Hi, this is, you would need documentation that, I guess, when the fall occurred. So if it's measurement period, that's what we would be looking for. Thank you.
Okay, thank you. And our next question, if a patient declines a depression screening, can this be excluded?
Hi, this is Katie from the PIMS team. So there's a couple different measures here. I'm gonna just go ahead and speak to both of them. So for MH1, there is no denominator exclusion or exception for patient refusal. In that instance, if a screening wasn't performed for MH1, we would just want you to confirm that they were eligible for the denominator based on that denominator identification period and determining whether they met the criteria for inclusion there. In regard to PREV 12, there is an applicable denominator exception for patient refusal. If the patient refuses to participate, as long as there's documentation in the medical record supporting the patient refused a depression screening, it would be appropriate to report the denominator exception. Thank you.
Great, thank you, Katie. And I did just see your chat about circling back to PREV 12. So was there anything else that you wanted to mention there?
Yes, so this goes back to the question that was we were just speaking about out loud over the phone. So just going back to the intent of the measure is to have a follow-up plan for patients who are screened positive for depression. So in the instance that they were positive for depression and no follow-up plan was documented, that would be considered performance not met. We understand that it might have been the clinicians up to their own determination whether they felt follow-up was needed for that patient, but to meet the intent of the measure, a documented follow-up plan is required. Thank you.
All right, thank you. And I think we have time for one more question. So is documentation of no depression in the review of systems sufficient as depression?
Hi, this is Katie from the PIMS team. Can you read that one more time?
Sure. Let me try to find that one real quick.
Okay, and I guess I can just go ahead and state that if this is in regard to PREV 12, the measure is truly just looking for documentation that a screening was performed, whether or not that was considered negative or positive, and if positive, a documented follow-up plan would be necessary. So again, CMS does not dictate your internal workflow. The way that's documented in the medical record is truly up to your organization, as long as you're meeting the requirements outlined in the measure specification.
Thank you for that, Katie. Okay, well, I believe that is all the time that we have for today. So we would just like to note that our final support call will be held next Wednesday, or I'm sorry, 2 weeks from today. So it will be on Wednesday, March 24th at 1 p.m. Eastern Time. Thank you so much for joining this afternoon.